Hi guys, I'm going to show you how to set up an arterial line. But first, I'm going to talk on how transducer works. So transducer are systems that convert a mechanical signal which in case of presence of monitoring either arterial line or CP line. So in order of transducers to work, it has to be connected by continuous fluid, either hypsilon or saline in the patient's body, ideally with no bubbles in it. So presence of the bubbles in the transducer system raise the conversion to keep the system off the blood clot and preventing the thrombosis forming at the end of the catheter. Now I will start my tubing using ANTT, which is aseptic no touch technique, by spiking the bag, the 500 ml fluid, using no touch technique. Then put it inside the bag, then hook it inside, then put a bit of fluid in the chamber and pump it to 300 mark, as you can see, until the green color appear. So this is 300 mark. Then turn the stopcock towards the bag to avoid any leak. Then enroll the clamp, and we're going to start priming the tubing in 2 stages by pulling the blue tag and to get rid of any air bubbles. As you can see, those clamps usually come in set with the little hole. Turn the stopcock towards the line going to the patient, then pull the blue tag, so you can see there is no error. So put the stopcock back to clamp. So and use a cap, which is a full cap, usually come with the set, using no touch technique, and put the cap back on. And the second stage to prime the second bit as well, as you can see, to avoid any air bubbles. This is a transducer lead. The circular bit on the left side, it connects to pressure monitor set, and the red color coded goes towards the cassette. The flat color red coded goes towards the cassette, with the rest of the baseline lead, while the other is a male and female coupling, as you can see. This is the chlora prep to clean the site, and this is additive drape to keep the site sterile, and is of course swab to clean or put some pressure on the site. This is a 4 type of cannula. The first one is Arterial Lead cut, which is a popular and mostly used, and the BD arterial cannula. So it depends on anesthetist preference. The old 20 gauge. Of course, there is an inside cannula. It's 20 gauge as well. And lastly is an Abocat 20 gauge as well. And you need a dressing for the cannula as well, and line holder to hold transducer, and you need a fluid. It can be hep saline or normal saline. It depends on hospital protocol. Either one can be used. Of course, you need a pressure bag for those fluid. Then you need a pressure monitor set. So it can be a single, as you can see, if you do only well like Artline or CVP plan, or it can be a double using the two of them, CVP plan or Arterial Line. So all those lines usually come in loose, so make sure that's all tighten them, and all the cups here come with this little hole to get rid of air bubbles. Once everything is connected, you can see a straight red line on the monitor, and if it's blue, all you can do is just swap the transducer lead. Then so for zero in the line is simply take the cup off to atmospheric pressure, then turn the stopcock towards the patient and wait and look at the monitor. Is red line. Once it's zeroed, put the cup back on, turn the stopcock towards the cup, and that's where you can see the outline is zeroed. That's all things you can see on the monitor. There are three main sites you can put an outline. The most used, the first option is the most used properly is radial artery. Is simply to get to. Secondly, is brachial artery is larger in size, complications in terms of access, hardened to bleed, and patient cannot keep their elbow straight. So for radial artery, it's get the hand in position by using the arm board, tape the thumb outward, external rotation of the hand, that straighten the radial artery. And the last option is the femoral artery, is the same as brachial artery, is larger in size, hardened to stop the bleeding. Also, the infection may occur because of the hygiene in that area. Hope this video is beneficial to you, and thanks for watching.